we are so lucky. This is the most extraordinary kind of focus on perioperative care and optimization of improving surgical wait lists. So Jugdeep, come on, come and do your best now. And just to remind everybody on the call, Jugdeep, it's Professor Jugdeep Dhesi. She is consultant geriatrician, a stalwart of Guy's St Thomas's NHS Foundation Trust, big fan of the Institute of Health and Social Care Management, and most importantly of all, currently president of the British Geriatric Society. So Jugdeep, please wrap this up for us, top and tail it as you would, and looking forward to hearing you talking about the identification and optimization of the complex surgical patient. So over to you, if I may.
Yes, I'm going to talk about the complex surgical patient. So I suppose we could think about Doreen, couldn't we, if we really do want to have a patient-centered focus. So a 78-year-old living alone, little support, difficult historian label in the notes, a little bit of osteoarthritis, diabetes, hypertension, and maybe goes along to her GP because she's short of breath. And these are the kinds of patients that we all see all the time, aren't they? Whether we're working in primary care, in community services, or in secondary care. But say, for example, Doreen ends up being identified as being anemic as a factor for her breathlessness, and then goes on to be discovered to have any kind of surgical pathology. To be honest, it could be elective or emergency. So what happens to people like Doreen in current pathways? Well, actually, as kind of Ramai's already referenced, probably quite a lot of these patients we don't actually see in secondary care, because out there in the community, they've actually declined intervention for a whole host of different reasons. It might be because we've not been communicating properly. It might be because they've not understood what we've tried to communicate because of sensory or cognitive impairment. It might be because she says, well, I'm 78 and I haven't got long left and I don't think I should be having anything done. Or maybe her sister had a stoma and she says, I never want to go there, don't want that, don't want to have any tests for this. Or maybe she does get through that bit and then she does come up and she does get seen by pre-op assessment, and there she's identified as having these 3 different things going on. And then the pre-op assessment nurse refers her to an anemia clinic, a diabetes service, and tries to get an echo for her shortness of breath. And so this lady who lives alone, who's got osteoarthritis, is socially isolated, tries to find her way around these different appointments in time, maybe for her 2-week wait cancer surgery. Or maybe actually that bit goes really well as well, and she comes in on the day. But then, as we've heard from Joe, we're still seeing 8 to 9% of our patients being postponed on the day of surgery, for a variety of different reasons. It may be that this particular lady didn't follow her instructions because she couldn't read them. Maybe it's because then she's identified as having this breathlessness that the anaesthetist is worried about on the day. And of course, similar things can happen in the emergency setting as well. But maybe actually all of that's done really well. And maybe she goes and kind of gets seen electively, goes on to a prehabilitation program. They look at smoking, alcohol, exercise, nutrition, counselling. She comes in, she has exemplary evidence-based ERAS program immediately pre-op, intra-op and post-op, goes to the ITU unit, and there has perfect physiological control for the first 48 hours, and then comes back to the ward. Now, we know that people who have got underlying pain, like this lady has from her osteoarthritis, end up needing higher doses of analgesics post-operatively. We know that people who have diabetes have slower gut transit. That, together with the opiates, means that she's not eating very well. So then we ring up the diabetes team. They come along and say, actually, we ought to put her onto an intravenous insulin infusion. That goes up. But she doesn't drink quite enough and we don't match her fluids and she starts to develop an acute kidney injury. So then we give her some fluids because we think she's a bit dry, and we ring the renal team and they say, well, of course you need some fluids. The fluids dilute her anemia, and then the juniors ring up the haematologists and say, well, we think we ought to give her some blood. So that goes in. And then as that goes in, she's sitting there tied down to these different drips and tubes with a low albumin level to start with. And then she starts to get some leg swelling. So then they ring up the heart failure doctors and they say, well, we ought to offload her. Let's give her some diuretics. that drops her sodium. The sodium drops, but we don't notice that, but we should think that she's being a little bit apathetic, not engaging. It must be that she's depressed. So then we put in some antidepressants. And you can see how this cycle unfolds, where you're trying to get all the right specialists involved along the pathway. But actually, what we're doing is causing hospital-acquired complications with delirium, deconditioning, acute kidney injury, and functional decline, such that she goes home worse than she came in, and needing that social support that we all know is so difficult to access at the moment. So I suppose that brings us on to, well, who is a complex patient? Because in some ways, Doreen doesn't look that complex. But as RAMI's data shows, around about 50% of the patient population that they've been looking at does actually fall into this group. So this is a large volume group. We've always talked about high volume, low complexity, but actually we've got a pretty high volume of high complexity patients. And when we're talking about the kind of the patient at risk, then it's really these kinds of outcomes that we're thinking about. We're thinking about being at high risk of clinician reported, patient reported, process related outcomes. So you can see exactly what patient group is particularly at risk. And certainly the literature over the last 20, 25 years now has shown us that the independent risk factors for adverse post-operative outcome, from whoever's perspective we're looking at that, relate to poor physiological status. They relate to socioeconomic factors and behavioural issues. They relate to the presence of multimorbidity rather than single organ disease, and to geriatric syndromes like frailty and cognitive issues. And this is a numerical issue for us. That's why it's 50% of our waiting list now being actually particularly, high risk patients, because 1 in 4 of our population is aged over 65. And we know that the things that we do surgery for, whether that's degenerative disease, neoplastic or vascular, they all happen with increasing frequency as people get older. So this is a numerical issue for us. And all of that really adds up to telling us, we absolutely need a new approach. We need transformation of our pathways. We've got increasing numbers of people living with complexity, and they're the ones who are having surgery. That complexity is what results in risk. We know that the majority of this population are going to be older because of that profile, and we've got to adapt our services because this is having system level impact. It's having impact for primary care, community services, secondary care, but also for social services and the workplace and pensions and, everything really across the country. So what does this new model need to deliver? And as Rami's kind of shown, we've been really kind of focusing on making sure that we do have patients and the public at the centre of developing any of these new pathways of care. And that's certainly the approach that's been taken in the development of POPs type services, engaging with local populations to work out what people want from the whole pathway, which is invariably, they tell us, needs to be joined up, seamless, honest and transparent, with a single point of access, delivered by people who want to kind of have a holistic view on what's going on with the patient. But they also tell us about the things that actually matter to them after surgery. And interestingly enough, a lot of that does relate to these hospital-acquired complications, particularly the impact of post-operative cognitive issues like delirium, people saying that their dad was never the same after that hip replacement, or related to functional recovery, actually getting back to independence. Those are the things that patients tell us matter. But they also tell us that it really matters that we help to support in shared decision making, that we switch the narrative from what's the matter with patients to what matters to a patient. So it's not so much what are we doing for this particular condition that the patient might have, but what can we do that will help with symptoms or quality of life, what might help with longevity and being able to live longer, but also talking about the mode of death and what might happen if we don't do something, and what's likely to then happen for the patient. But I think often when we talk about co-production, we focus very much on patients and the public, and that's kind of rightly so. But it's equally important that we understand co-production from a healthcare professional's point of view. And Joe kind of mentioned that about kind of primary care and how they've been engaging with the work that Ramai has been looking at. And certainly here again, when we've been looking at the complex surgical patient, we've explored what surgical trainees kind of understand about this, what anaesthetists and primary care practitioners understand. So then we can make sure that we're developing pathways that the healthcare profession is bought into, because otherwise you're again enforcing a particular pathway onto a population and then expecting them to get on with it, rather than understanding what they want to be able to deliver as well. So all of that work really kind of for the complex patient really sums up into telling us that we need to understand how to identify issues through screening, assess and diagnose these issues within this population, but focus on optimisation across medical, functional, social and psychological domains, so that we are looking at the patient as a whole and we are planning care throughout the perioperative pathway with hands-on involvement, all of which needs to be underpinned with shared decision making. So that's all kind of well and good, isn't it? Because that's all the kind of theory and what everyone tells us that they'd want to happen. But how do we actually make this happen? How do we operationalize this? And of course, that does absolutely have to start with systematic identification of these risk factors, of identifying the high risk population or the complex population. And again, here, this is where, you know, this data and approaches that both Joe and Ramai have referenced really come into their own, because we absolutely have to be using data from primary and community care effectively to be able to build up the picture of that population. We need to embed screening at the front door, wherever we describe that front door being, whether that's out there in the community, and certainly lots of work that we're doing from the British Geriatric Society working with primary care at being able to describe the population locally for them. But also in the surgical setting, in the emergency setting, we have now been working with the Royal College of Emergency Medicine to embed triple assessment for all over 65s coming in at the front door. So everybody should have a NEWS score, but also a 4AT to assess for cognition and a CFS to assess for frailty. Because then we can start to triage people as early as possible, even through that emergency pathway. And then in the elective pathway, we've got the preoperative assessment screening tools that Joe has mentioned already. But within that, we do need to start to make sure that we're focusing in on things like polypharmacy, which we know are risk factors for people doing badly. And these are relatively simple tools that we can embed into preoperative assessment, as Ramai has shown. And of course, all of that is advocated through national guidance now. And an example being for the frailty side of things, we've got the CPOC BGS guidelines for frailty in the perioperative setting, both elective and emergency, with very clear kind of infographics and things that we can use to be able to embed these relatively straightforward models of care. So we can identify people, but then what do we do? And I think this is where we need to work with the whole of our workforce, whether that's again out in primary and community care, or whether that's in the first surgical consult or at preoperative assessment. And there are so many different resources available for this. The amazing kind of 1 minute, make every contact count approach that primary care practitioners use, for example, for smoking and alcohol and weight management. Lots of resources around frailty available from the Frailty Hub at the BGS, shared decision-making resources, and summing up and signposting to lots of these different resources through the CPOC website as well. But we need to encourage our staff to be using every one of those contacts to make them count for the patient. because that's when it allows us to start care off on the right foot. Because if you've picked up that someone's got a 4AT that indicates that they may be at risk of cognitive issues, then you can start to talk to patients about the risk of delirium and use resources from the delirium hub at the BGS to have those conversations. And you can start to use your local guidance to ensure that we're getting everybody recognizing that this patient is at risk of delirium and what can we do to avoid that happening through the pathway. So lots of resources there that we can be using again. But that's also the point at which we have to acknowledge when additional expertise is required. Because if you've again described that population really well at that first encounter, then you can identify who needs to be seen in a high-risk anaesthetic clinic or who may actually benefit from geriatric medicine within that setting. And this is kind of where the CGA-based model of care comes into its own for patients, particularly living with multimorbidity, frailty or cognitive impairment, functional issues, or whether a difficult decision-making issues where we're not quite sure whether surgery is or isn't the right thing. And this is the schematic for the POPs model, which was started at Guy's and St Thomas's, but has now been established at kind of 40 UK hospitals, 10 over in Australia, and kind of a number across Europe as well. And again, this is all to be used. So, you know, these are things that are freely available for everyone to access and start to use, including, you know, for example, our referral posters that we have up in our surgical consult clinics. And that is where it allows us to deliver care in a one-stop service, which is what our patients have told us that they want. So people like Doreen not wanting to go to a diabetes anemia clinic and then go for an echo and everything before she comes in, but instead go to a CGA-based POPs clinic where what we're finding is that we're making 2/3 of our patients are having a new diagnosis made in clinic, lots of things unrecognized for lots of different reasons. 3/4 having their medicines changed, a lot of therapy and lifestyle intervention. Interestingly enough, only 1 in 20 being referred on to another organ specialty for any advice. So this can be delivered in a one-stop service. You do not have to send these patients to multiple clinics. And of course, that's really important for our waiting lists, when we know that 1/3 of all 65-year-olds across the country are on at least one waiting list, and many of them are on far more than that one. The other thing that happens through this service is that we find that 1 in 7 patients choose not to go ahead with the operation that was originally proposed. That's because we've been able to describe the wider benefits and risks, the alternatives, and what will happen if we do nothing with those patients. And actually, that increases up to 1 in 4 in the abdominal aortic aneurysm population. And again, I can go into the detail with you for that. But what's probably one of the most interesting things about this is that if you follow those patients up at a year, around about 40% of them have died at a year. But the majority have died of non-aneurysm related causes. These patients were in the last year of their lives, and yet we were planning to put in this expensive aortic graft, which isn't good for the healthcare economy, but most importantly, it's not good for a patient in their last year of life to be spending their time going back and forth to hospital. So lots of interesting stuff that's come out of that paper. And we know that this can be implemented across the country because we've now established this at other POP centres, seeing almost exactly the same results between 1 in 7 up to 1 in 4 patients choosing not to go ahead with an operation after a full shared decision-making process. So if we go back to Doreen, kind of what happens for somebody like her? Well, of course, it depends on whether it's emergency or elective surgery, but there's lots that happens. But it does require quite a lot of putting together of different guidelines, using the evidence base that we have, extrapolating that to that individual patient. So it's interesting medicine, but it does require a specific skill set to be able to do all of this in a one-stop clinic. The other question that we often get asked is, well, isn't this the same as prehab? And actually, that's really interesting, because what we're seeing from the prehab studies is that we're not seeing the same benefits for older people as we're seeing for younger people. And that's probably because prehab traditionally doesn't include the medical bit. And there's so much medicine, kind of those new diagnoses, medical management changes that are happening in a CGA-based approach that doesn't happen in a prehab program. But you can see then, if you do all of that stuff well up front, then it allows the post-operative period to be delivered in a much more planned approach, where you're able to identify what the risks are, manage them better, co-management on the ward with proactive identification of complications and management of them by a team who knows the patient. And we've seen how that approach really does improve outcomes. So we know that 40% of delirium is preventable. We know that deconditioning is preventable. We know that we can reduce length of stay by 40% by these types of interventions. The question often then arises, yes, but that's really expensive. So how do we actually do that? And these are just some of the metrics that some of the hospitals that we've worked with have used to illustrate how refashioning the money actually delivers cost savings. And we've done some academic work that shows that we save around about £1,500 per patient by using this approach. So it's actually cheaper than our current ways in which we deliver this type of care. So these are just some of the metrics there. The other question is always the workforce. Well, where do we get the workforce to deliver this? And again, this is about refashioning our workforce rather than asking for more, because we all know that that's not going to happen anytime soon. So how do we upskill people who we currently employ to deliver patient-centered care for the majority of patients sitting in hospital beds? 66% of our beds are occupied by people aged over 65. Everybody needs to know the basics of geriatric medicine. And again, these are some of the programs that we've established to support education and training. So what about implementation at scale? That's another session of another whole, probably lunchtime session, John, where it's talking in more detail about funding workforce, the real importance of standards, processes, but also cultures, the use of quality improvement and implementation science to be able to embed these types of services. But at the moment, we are running a big NIHR study across 18 hospitals where we're looking to see, can we implement these types of services in late adopter sites? And do they still deliver clinical and cost effectiveness in those very different types of hospitals, district general hospitals across the 4 nations? So more to come from that. So what should everybody do today when they go back home? Well, probably it's Friday, isn't it? So probably have a cup of tea or something stronger and have a nice weekend if you're not working. But otherwise, we should all be recognising we're all going to be looking after older people living with complexity. We absolutely have to embed appropriate screening tools into preoperative assessment, which are easy to deliver, but identify the high-risk population early. We should be using our data to inform our local services, whether that's NELA, NHFD, or that from GERFT. Lots of education and training resources like those on the BGS website. We've got to be multi-specialty in our approach rather than being single specialty focused. Patients are not presenting with single comorbid conditions anymore, and there are lots of resources available to support everybody in doing that.
Goodness me, Jugdeep. I mean, I think you've nailed it. Congratulations. I think this is just box office. And not only, I mean, I've been watching the slides as you've been talking, but the thing I really marvel at is the sheer number of clinical studies that you personally have contributed to having published. I've got no idea where you find the time and energy to do all of that, but it is extraordinary. So thank you. If any of us really wanted an expert analysis of just what's going on in terms of geriatric frail older people and some of the considerations, I think you've absolutely nailed that. So thank you. And in that I sing in a male voice choir, and as with many male voice choirs, they tend to be slightly older people. I might even take some of these slides and show them, to be quite honest. Or better still, bring them all to Guys at St Thomas's and we'll come and sing for you. And you can ask them in person.
Yeah, no, that'd be absolutely amazing. And John, I think, the importance about the research is, it is so key. But I think just to reassure others on the call, I've been employed in a full-time NHS clinical contract throughout kind of my consultant career. So, but the work's been done by clinicians. And pretty much every one of these papers has had one of our junior doctors who's, again, in a full-time clinical post, really committed to, delivering patient-centered research that they feel makes a tangible difference on the shop floor. So, it's all kudos to the wider team, our resident doctors, and certainly our clinical nurse specialists within our team as well. So that's kind of reflects back on what Ramai was saying. It's the team, isn't it, that is absolutely key.
Well, and many of the people on the call today will not know that Jugdeep's actually on annual leave at the moment. So she's dialing in, she's giving up some of her holiday to come and talk to us and share her expertise. We've got about 2 minutes for questions. If there are any questions, to be quite honest with you, it's almost superfluous because it was all so comprehensive from 3 absolute titans of surgical waitlist management. And I can't believe anybody would have a question, but if you do, act now. You see, I was right. Everybody's just dumbfounded by the excellence of what they've been presented with. Goodness me. Well, I have to say, as kind of hour and 12-minute sessions go, that's just flown past. So that's entirely thanks to the excellence of our presenters today, Joanna, Ramai and Jugdeep. And my goodness me, we've been an absolute treat for us all to listen to all of that. So thank you so much. Jade, the fabulous, the one and only Jade Maloney, our operations manager at the Institute of Health and Social Care Management, has put links for all of the different slide presentations in the chat. So if you would like to download any of those, please do that now so that it's not the kind of screen hasn't suddenly vanished and you're thinking, oh blast, I wish I'd downloaded it. But all I'm going to say is to all 3 of you, thank you so much for giving up your lunchtime and coming to chat to us. I know this will have hundreds, if not thousands, of downloads as we make it available through recording now. So thank you very much, and please keep up the good work that you're all doing. It is noticed, it is valued, and we do appreciate it, and that's for all of your colleagues as well. So thank you very much. Let's wish them all bye-bye. Have a super weekend, everybody. If you are working, thank you very much on behalf of the rest of us citizens, and we'll leave it at that for today. Thank you very much for tuning in. Bye-bye.